Hello, this is Joe X, Professor-in-Chief of the Division of Nephrology and Hypertension at UC San Diego. I'll be discussing the publication Nicotinamide and Phosphate Homeostasis in Chronic Kidney Disease, authored by Charles Ginsberg and myself, Joe X. The study report was published in Current Opinions in Nephrology and Hypertension. We selected this article to discuss because it reviews the approach to decreasing NaPi2b expression. Although phosphate binders are commonly used to lower phosphate, they've been proven to only be minimally effective in CKD, and meanwhile, the management of hyperphosphatemia remains a major clinical challenge. Because of the associations between hyperphosphatemia with morbidity and mortality in CKD, there is great interest in lowering phosphate in clinical practice, and specifically using and managing phosphate binders in earlier stages of CKD. Nicotinamide, also known as vitamin B3, has been shown to decrease intestinal phosphate transport in animals. However, its efficacy and safety in CKD remain uncertain. This study compares the metabolism and side effect profile of data differentiating nicotinamide from nicotinic acid or niacin in patients with CKD and in the general population. The review focuses on emerging data surrounding the use of nicotinamide and its derivatives for phosphate lowering in patients with CKD and end-stage renal disease. From the lead author's perspective, there are several important highlights to this study. The study summarizes the present literature on the use of intestinal phosphate binders in CKD patients, and highlights the relatively low efficacy in this setting. It also summarizes animal data showing that intestinal phosphate binders increase expression of the major sodium phosphate cotransporter in the small bowel, NaPi2b. The study summarizes data demonstrating that nicotinamide suppresses NaPi2b and summarizes the experience of use of nicotinamide in patients with kidney disease. The paper lays out a strategy of how nicotinamide may be useful for managing hyperphosphatemia in CKD patients, either in isolation or perhaps in combination with intestinal phosphate binders. I think the study can have important implications to patients with CKD and MBD. If nicotinamide is found to be effective for phosphate lowering, as well as safe and well tolerated, it would provide a new strategy to treat patients with CKD-MBD. This study has several important key findings. Because of limited efficacy of phosphate binders in early CKD, new therapies to lower phosphate in CKD are urgently needed. There is increasing interest in the use of nicotinamide and niacin for inhibiting sodium phosphate cotransporter 2B or NaPi2b in CKD. Data suggests that nicotinamide may influence transcription or translation of NaPi2b, or influence other circulating regulating factors that secondarily impact NaPi2b function. The review differentiates nicotinamide or vitamin B3 from nicotinic acid or niacin, while although they have similar functions as vitamins, their pharmacologic and toxic properties differ. When niacin is taken orally, it's converted to nicotinamide, and in high doses, it's sufficient to induce flushing and lipid-lowering effects before complete conversion to nicotinamide metabolism or excretion. Sodium-dependent absorption is primarily through NaPi2b located in the small intestine, and nicotinamide decreases sodium phosphate concentrations by inhibiting sodium-dependent phosphate transport in the small intestine. In animal models, particularly in rats and mice, studies provide insights into intestinal phosphate handling. Nicotinamide decreases expression of NaPi2b cotransporters in the small intestine in animal models. And nicotinamide consistently lowers serum phosphate concentrations in ESRD patients. Study results show that nicotinamide is a novel potential tool to treat hyperphosphatemia in patients with CKD, but we still need additional data on the safety and efficacy before its widespread clinical use. So here are some highlights of major points of this study from my perspective. Although widely used, intestinal phosphate binders really have minimal efficacy in lowering phosphate concentrations in CKD patients. This may be in part because they upregulate the key sodium phosphate cotransporter NaPi2b in the small bowel. In contrast, nicotinamide lowers NaPi2b expression. The study summarizes the effects of nicotinamide on NaPi2b in animal models and in prior studies in patients with CKD and end-stage renal disease. To date, studies consistently demonstrate that nicotinamide lowers serum phosphate concentrations. The study also highlights the distinct mechanisms of actions of intestinal phosphate binders and nicotinamide, and suggests that the two agents may actually have synergistic effects on phosphate lowering. These results may ultimately have impacts on patient management. At present, the study doesn't directly impact patient management. However, randomized clinical trials are ongoing that are testing the efficacy and safety of nicotinamide in isolation or when combined with a phosphate binder in CKD patients. These trials will be completed within the next 2 years, thus the impact on clinical management may be changing in the short term. In addition, nicotinamide is not marketed as a drug in the US, but rather as a vitamin. Thus, it's readily available and inexpensive. It may provide an opportunity to treat patients with CKD-MBD around the world, even in resource-poor settings. With this, though, many questions remain unanswered. In particular, the efficacy and safety of nicotinamide in CKD and dialysis patients is not yet fully established, and trials are ongoing to address these important questions.